Well, it's wonderful to have so many Denverites in the room, and I'm welcome to so many of you from New England and Tennessee, Ohio, and so many great places. We're excited to have to share again, like I said, a little bit about our work, but also to really make this more conversational. So, I think for many of you in the room, it won't be a surprise to see that as a low-income housing provider, Mercy Housing every day sees people in properties struggling with healthcare needs. And our corporate headquarters is in Denver, but we have properties in Washington State, in California, in the Chicago area, as well as in Atlanta. And I think that what we found over the last few years is that even though for many people living in a Mercy property is the first time that they've been able to call a place home for a very long time, and they're able to feel a new sense of security and confidence, that there are so many healthcare needs that people continue to struggle with. And so our interest for a long time has been, what role can we play as an affordable housing provider to help people connect with healthcare and really improve their own health and well-being. At the same time, we also recognize that many of the residents that we have can be pretty challenging for the healthcare system. That we have individuals and families who may have health insurance and may go off of that health insurance. They may have chronic health conditions. They may be, fairly difficult folks for the medical community to continue to see on a regular basis. And that many don't lead the kinds of healthy lifestyles that would really be most beneficial. So, Mercy Housing took a step back a couple years ago and said, we need to get a better handle on the health of our residents. We're so much more than a housing provider. We need to better understand, what's happening. And so what we did is we conducted a first of its kind annual resident health survey. We conducted this survey in all of our properties across the country, as well as those here in Colorado. Again, to get some data on how people were doing and what their needs were. But after we received that data and we began to digest it, we recognized that we were really never going to be able to address these challenges alone, as I'm sure will come as no surprise to those of you here in this room. That really was going to take, much deeper collaboration and much deeper exploration to truly understand what this healthcare data meant. And so it was really at that time that we turned to our collaboration with the Colorado Coalition for the Medically Underserved. And I'd like to say that we were so visionary that we said, Gretchen Hammer is the person that we should be working with at Colorado Coalition for the Medically Underserved, which we call affectionately CCMU. That's easier to say. Rolls off the tongue. But it was really one of our residents that got us thinking. It was a resident at one of our supportive housing properties here in Denver who one day struck up a conversation with a passerby. And it turned out that this fellow he was talking to worked for the Colorado Association for Health Plans and was on his way to testify at the state legislature. And that property is close to the state capitol. And so this gentleman, Lawrence, started this conversation and said, I think you should come to the property that I live at and talk to our residents about the work that you do and the Affordable Care Act, because I think it's going to impact a lot of their lives. And this man, who he's talking to, Mark Reese from the Association of Health Plans, said, well, I'd be happy to do it, but I want to bring Gretchen Hammer along from CCMU, because I think that she can answer all the questions that you have. And I was lucky enough to get invited along too somehow along the way, and I think that I can speak on behalf of Gretchen, Mark, and myself when I say that we were pretty much blown away by the conversation, that what we thought was going to be more of an educational opportunity really became a very meaningful dialogue with an awful lot of listening, and that what we recognized is that the conversation really turned a lot of conventional wisdom on its head. And so afterwards, when Gretchen and I were talking, we said, we need to find a way to go deeper with this. We can't just let this stop with one dialogue, because we feel like we're starting to scratch the surface on a lot of really important information. And so luckily, there was a funding opportunity that came along through one of our local health foundations, the Colorado Trust, that was funding groups that wanted to convene around specific health issues. And we submitted a joint proposal for a convening grant that would allow us to convene residents and also to convene experts to talk about housing and healthcare linkages here in Colorado. And so the first part of that convening was really to launch a listening tour, to go to all of the 6 Denver area properties and to have this deeper conversation with people about what some of the health data meant that we had collected and what some of their ongoing needs were and really what their ideas were for improving their own health and well-being. So I'm going to spend just a few minutes giving you an overview of the health data that we collected, and then I'm going to turn it over to Gretchen, and she's going to share more with you about the listening tour results, and you'll hear some things from our own residents in that presentation. And then we'll be talking about some of the key themes that rose to the top and want to be able to talk to you a little bit about what all of it means. So that's where we are, and I will just turn to the PowerPoint. So, you know, I think when we talk about the survey, it's important to start with just a sense of who the Mercy Housing residents are. And before I go into some of that demographic data, I will talk a little bit about the methodology in that the survey itself was a self-administered survey that we conducted over a 2-week period last fall. And it was conducted there on site, and residents were given the opportunity to complete it themselves, but if they wanted some extra help, we had resident service coordinators available to help them with that. And the questions covered areas like health insurance, healthcare utilization, healthy behaviors, and we received a 79% response rate, which we were really delighted with. But again, when you're surveying where people live and you're able to follow up with folks and give them some, incentives and things and food, it all helps. And we were able to get 1,009 residents, data on 1,009 residents here in Colorado through this process. And again, we have processes going on like this all over the country, but for the purposes of today's discussion, we're going to really focus on Colorado. So the first thing we learned was a little bit about the demographics, and I've just given you a few highlights here, and I think the big takeaway here is this is a very diverse group, particularly racially and ethnically. We had, especially with the children, you'll see that we have about, a split, 30%, about a third white, a third African American, but also pretty large numbers of Asian Pacific Islanders at about 12%, and about half of the kids were identified as having a Hispanic background. The numbers for the adults are also, they're pretty diverse. Again, we have about 38% of the residents who are white, about 30% black, and about 17% Asian, and just about a third who identify as Hispanic. You'll see here a little bit about the average age. Again, adults a little bit on the older side, age 38, and children average age about 7. And I should note that Mercy Housing has family properties, so we were surveying at family properties clearly, but we also have several supportive housing properties, so those tend to be older adults without dependents, and then we do have some on our properties. Oh, yeah, and I think that's a great point, Gretchen. We also have a property that is primarily refugee families. So many families from Burma and from Bhutan in particular, and we had a great listening tour with them too. So they're part of this data as well. So our first question, and it was actually a series of questions, so again, we've tried to condense this a little bit for you. Our first question was around health insurance, and I think that we were pleased to see that, again, we have about 96% of the kids who are covered with health insurance, which I think we were pleased by. We would anticipate that all of them would be eligible for health insurance, but at least we're getting pretty close to 100% there. For the adults, it's less. We have about 75% with public health insurance, mostly Medicaid, some Medicare, and some who are dual eligible. But again, we have about 28% of the adults who are not covered by any health insurance. Many because they are not eligible for Medicaid. We don't have dependents at home anymore. And this is really this group that we think are going to be newly eligible with the Affordable Care Act if we look at Medicaid expansion here in Colorado. This is a group that we want to spend more time with in the next 6 months. We also asked about healthcare usage, and we asked about primary care providers. Did they have a physician who they consider to be their regular doctor? We did not use this term primary care provider in the survey. We tried our best to kind of take the jargon out and make it easier to understand. And so, again, we have about 62% of the kids who do have a pediatrician or a family doctor who they see regularly, and about half of the parents. And I think that Gretchen will tell you a little bit more about what this seems to mean and what some of the implications of this data are when what we uncovered when we had the listening tour. But again, this kind of gave us a snapshot that it seemed to be that things seem to be going a little bit better with the kids than with the adults. We asked how recently they'd had a routine checkup. And again, we had about 82% of the kids who've seen a doctor within the year, and I think that needing to get immunizations and all of that really helps get those rates up. With the adults, it was a little bit less, but still pretty significant at 68%. What we were surprised by were the number of ER visits. Again, we're an affordable housing provider that has resident service staff available, so we do have people that are there to help people navigate the health system, try and get health appointments. They're not there on their own, though. We all have challenges getting an appointment in a timely manner. So we had, about 35% of the kids go to the ER in the past year, and we had about even more, 41% of the adults. So again, this blue bar are people who visited the ER once in the last year. The green bar were 2 or more times. So pretty significant and higher than we would have expected. We asked a series of questions around exercise and nutrition and just people's sense of well-being. The one that I wanted to point out to you today is around eating vegetables. People really struggle with eating healthy and getting the right exercise, particularly, again, the adults. So we had about a third of the adults who never have a vegetable, and about a fourth of the kids who never do. And the findings for fruit weren't a whole lot different. I think they were a little bit better, perhaps. So again, I think there's some room for improvement in terms of, helping people lead the kinds of lifestyles that lead to good health outcomes. And then finally, we asked a series of questions around emotional health. And these were kind of tricky questions to ask. And so I'm not sure that we're completely satisfied with the questions, but we looked at the literature and we pulled out a few, and we thought we would pilot them. And some of the questions kind of asked the question around emotional well-being, kind of using this phrase, how often have you felt downhearted and blue? And again, we have about almost half, about 46% of the adults who reported that they feel downhearted and blue either all or most of the time or a good bit or some of the time. And I think we would have expected some of that, again, because we do have supportive housing properties and we do have people who've had chronic health or chronic mental health issues. But, many also are receiving treatment, and so we were hoping that, perhaps that wouldn't be quite at that percentage rate. So that's a little bit about the survey, and I think before we talk more about what all this might potentially mean, I think I'd just like to pause here and give you a chance to give us your reactions. As I've presented on these slides, is there anything in this data that surprises you? Or is it all exactly as you would have predicted? Yes? That's a great question. We didn't distinguish that on the survey, but we sure dove into that on the listening tour. So I don't want to give away all of the excitement of your findings, so I won't comment, but it's an excellent question because we wondered the same thing. Yeah. It was both. Yeah, we did have one property where there was a significant difficulty getting the provider. The health clinic had actually moved, and it was no longer accessible by the bus. And it was just to kind of try and walk there from the closest bus station, putting your life at risk because highways and this kind of stuff. So with that case, there was also a case of people trying to make appointments and being told it was 6 months wait. And so they're kind of scrambling, like, okay, well, you don't really have the luxury of a regular provider when you just need to call somebody who's going to see you in a reasonable time frame.
I think we also heard in the listening tour that, the way you ask that question can guide people to a different answer. If you have a primary care clinic where you feel that that's your medical home, you may not identify, though, with a single provider. We heard a lot of people say that, frankly, they felt like cattle being moved through the healthcare system, that there was not, one of the residents made a great comparison to, in his daughter's preschool class, there's a ratio of preschool teachers to children, and he was like, why can't we have the same thing in healthcare? We're just a number when we show up. So I think there's some nuance to that question of, do you feel like you have a single person healthcare provider that you identify with as a person you could call, or do you have a clinic that you say, I can go there and get services when I need them, but it's sort of an amorphous place and there's not a single individual? And I think we heard residents talking about both of those experiences.
Anything else? Yeah.
Yes.
Yes.
And or multiple safety net clinics with family residencies and those kinds of other care providers beyond the traditional federally qualified health centers. 5 of the properties are in Denver, which then make them part of the Denver health system and the network of community health centers that are the primary care clinics. And 1 is in Adams County, which also has a federally qualified health center.
Yes. Right. That's a really great question, and we have one property where we might have some folks who are, but I don't think that explains this 25% at all. No. It's not a significant number. I'm curious, have any of you used a survey, a health survey in your properties, if you're housing providers? And, I don't know if you have any reflections on that exercise. Found that useful, or any kind of process that you've used that you found has been really helpful. Great to hear. Yeah.
So, did a similar survey in Seattle, and we do you have a regular document of figures that not medical, but we asked 2 extra layers of questions that were really interesting. One was, if you said yes, who is that? Who's your regular doctor? And had a fairly large portion, it was in just one housing area that has a hospital around the country. They listed the hospital in ER as their regular doctor.
Yeah, that's good.
And so it was sort of like, okay. And so then it was, we asked, how did you originally like that? Like what? And it was interesting because there are multi-generational residents community. They grew up there, and they know their stuff, and they said that's what I was.
Yeah.
So it was like, well, we needed to sort of change generational patterns, right? But it helped us sort of line so now kids now and realize they wanted to change some of the things on just always we are.
Yeah. 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 Well, I'm going to segue. I think this is the perfect time to turn it over to Gretchen because she can shed even more light on this issue and others.
And I'm going to just stand over here because mostly what I have is narrative, and so I want folks to see. I think that, one of our goals, Susan and I, when we were preparing for this session, was to we think, share both the methodology and the results. And so to the points of some of these questions, when you just look at the survey data, there's a lot of things that you continue to want to really understand. And so after the great experience that we had at Aramore, thanks to Lawrence, when we went around to the properties and went back to Aramore, we used the survey as the hook to get residents to come back. And so we promoted the listening tour to say, you all filled out a survey. We'd like to understand what it really feels like when you access healthcare services. And so the resident services coordinators did a great job at getting a number of the residents to come back and talk about the results of the survey. And so similarly, we shared those results. So we would say things at the beginning of the listening tour like, about a third of the kids in this property haven't seen a doctor in the last year. What is that? Does that make sense to you? Is that different than what you thought it would be? And so we tried to use the data to open up the question, because it's really hard to start a conversation with a group of people and say, so how's healthcare working for you? There's no place to get in there. And so we broke it down by those who, if you don't have health insurance, and I think our first property we had health insurance and healthcare separate, and it just was glommed together throughout the entire dialogue. So we stopped separating out that data and just putting it together and saying about a half of people who live at this property don't have health insurance, and 1 in 3 of the residents here have a hard time getting a doctor's appointment. Does that sound about right? And I think one of the most powerful things is at that point we stopped talking. That was the only question we asked, and then we let the residents talk the rest of the time. We asked the same sort of very open-ended questions of, like Susan said, a quarter of the kids at this property don't typically eat vegetables. That's surprising to you? How does that make you feel? So it was really interesting we called it a listening tour because that's what we wanted to do. We wanted to listen, and it was very powerful, and many of the residents at the end of the conversations said, thank you for listening. Thank you for just coming here and not having a PowerPoint presentation. And most of the resident service coordinators ordered pizza or something, and we sat and shared a meal while we chatted. So I think that was just another piece of the process that's important to note. But what we really heard, as we've already begun to discuss, is that around access to coverage and care, there are significant barriers accessing care. So despite the fact we live in an urban community with very robust community health centers, that waiting times and emergency room utilization, very significant. We did have residents say to us, I don't like using the ER. I know it's not the place where I get good care. I don't get any follow-up. If they identify something, it takes a long time. And if you're uninsured, you get a huge bill. But I don't really have any other choices. I don't feel like I have any other choices. And so it was an interesting piece for us to reflect on that to Susan's point, the level of sort of sophisticated reflection on that emergency room utilization was really very telling, that there would be a preference for other options if other options were more available. We also heard varying themes around relationships with providers. Some of the residents who have a strong and trusted primary care provider relationship talked glowingly about how important that was to them. How important it was for them. It coordinated. There was a coordination factor there. There was the ability to, you know, when you didn't understand what medications you should be taking, to just pick up that phone and make that connection. And so for those residents who have those primary care provider relationships, very strong. We did have a couple residents complain about the fact that most of the time they're seeing providers who are in training, and so they know they're only going to be there a short period of time. And so a couple of the residents said, yeah, I'd like a long-term relationship with a provider, but I always get these young interns, and they're, you know, I think the woman was like, they're cute and everything, but, you know, then they move on. Like, I appreciate them, but then they're out of here. So it was very interesting. And we did hear a little bit of pushback, which was another surprising finding, on being seen by a mid-level provider, being seen by a PA or a nurse practitioner. Some of the residents said, no problem. I trust them. I know them. We have more time together. Others said, I think I'm getting second-rate care because I'm not seeing a doctor, and I think it's in part because I have Medicaid, or it's in part because I live in this apartment housing complex. So some concern or some confusion about what kinds of providers they had access to, given their kinds of coverage, in particular Medicaid, those patients who were covered by Medicaid saying, I think I only see nurses because that's all Medicaid will pay for, which isn't necessarily true, but the perception of the residents. Dental and vision came up in absolutely every conversation. And it was great that we had these conversations in January, because my organization does both policy and community-based work. And we were able to work with the state legislature this year and get a dental benefit in our Medicaid program. We've had no adult dental benefit. For pregnant women, people with disabilities, no one covered by Medicaid. And that law was passed, and we were able to use quotes from the residents as we talked with about the importance of dental health for their ability to secure jobs, for their ability to navigate the world. Similarly with vision, you know, there's one great quote that said, you know, you either walk around with no teeth and blind as a bat if you're on Medicaid, or you find some sort of you know, charity care provider or something like that. So very interesting that dental and vision, you know, we typically land on mental health issues and primary care issues, but dental and vision came up absolutely in every conversation we had. And then similarly, cost. Very difficult to feel like, even a couple of the folks had private coverage because of either a pension or something, and then to feel like they still got a big bill, even though out of their check every month was coming coverage, you know, a cost for coverage. Very difficult to feel like that felt fair. And that if you went to the ER without coverage, the cost that you incurred because of that was significant. In terms of navigating the healthcare system, we heard an interesting theme. Yes, ma'am. Sure, of course. Well, it's that bill, and also we have a $1.50 copay roughly for medications in Medicaid, and we did have some residents who are at zero income. And so a $1.50 copay or a $2.50 bus ride to the clinic, those costs were significant, and they perceived very much barriers to accessing care. So it was not just cost once you've accessed care, but costs we perceived, Susan, correct me if I'm wrong, but to some extent, cost was an upfront barrier to engaging in the healthcare system at all because of either an anticipation of a bill or a copay. Cost around dental coverage, you know, we had one resident say it's like $300 for them just to look at your mouth. Like, no services rendered, really, just a look and an evaluation, and that was just cost prohibitive. So there was an interesting interplay with cost. It's also upfront barriers. Same thing? Okay. So navigating the healthcare system, very interesting. Sort of three major themes there, that many of the residents who had previously been homeless felt like there was a lack of healthcare services access as they became more stable in their housing. So the ability to get care from a mobile clinic or to access care at the Coalition for the Homeless Stout Street Clinic, as they became housed, that became less available to them. And we've talked to the Coalition for the Homeless, and we're in current discussion about how we can smooth that path, if you will. But it was pretty interesting to hear, you know, whether or not they had the ability to access medications when they were homeless. But an interesting sort of finding there. really a lot of system exhaustion, for lack of a better word. And for those of you who help people navigate the system every day, I'm sure that this feels right for you. But you know, one resident shared that she, in her words were, "I was lucky enough to have a job. And then I got a letter from food stamps saying they wanted their money back." And she's like, just this constant sort of able to move forward, and then the system comes back and puts a barrier up. And it happened in a variety of places. So a lot of just frustration. You know, a couple of the residents, as to Susan's point, showed up with letters from the state Medicaid agency that they didn't understand, and frankly, I didn't either. As you know, I tried to help them understand what they said. So the rules in the system that conflict. You know, we also in Denver, and we heard this from our properties, and I'm sure this happens in other states as well, the jurisdictional lines between counties, when healthcare systems are aligned with the county. One of the properties is right on the Denver-Aurora County, or Denver-Adams County line. And so if a resident was taken to the university ER, but they live in Denver, the university being in Adams County, they were put back into the Denver system for follow-up care, and very confusing. The Children's Hospital of Colorado is in Adams County. If you were in Denver Health, that was in Denver Health's catchment area in the city and county of Denver. So just a lot of confusion along jurisdictional borders. I'm sure it happens on state lines as well as county and municipalities, but we heard that. And then, just to be frank, we heard about a lot of poor customer service experiences. That when people call, one of the residents said, you know, it's like it should be your lucky day that they answered the telephone. You know, like that really poor customer services experiences across the board, at the care provider place of care provision, at the state agency, the county agency, all across and all around. Not for the Mercy Housing properties, or not within the Mercy Housing structure, but the sort of external structure. Emotional well-being, what I think we heard most frankly, and again, this doesn't come as a surprise, but the stress of navigating the world with such limited resources and with such highly constrained systems adds to emotional not well-being, for lack of a better word. So when the residents were abundantly clear, I said, are there other things that impact your health beyond coverage and care? Because we had talked about coverage and care. And almost immediately, the daily stress of life, the daily stress of navigating the bus route with my 3 kids, the daily stress of other things, isolation and loneliness. And then Mercy does have in some of the properties on-site mental health supports, and many of the residents said that those were very, very appreciated, as were accessing some of the local behavioral health resources. But that if something went awry, if you didn't have bus fare that day, or something changed, that access could feel precarious. And so that was another piece of the emotional well-being. The last, and we put this here because it was important, and it was this notion of humanity and decency. A couple of the residents said, as I mentioned earlier in one of the comments, that the healthcare system many of the residents feel like the healthcare system does not treat them well. It's difficult to navigate. It is punishing. It is without compassion at times. And so treatment by society being important, interaction with healthcare providers, and then the customer experience, that some basic humanity and decency, which doesn't cost anything, frankly. We could all do that. Was a really important theme that the residents asked that we pursue. If we could, I think one of them said, if everybody could just remember why they went back to school, why they engaged in this work in the first place, the system would be better than it is today. So a very important finding, but not one that you can really, there's no policy to be implemented or system to change, but rather it's the tone in which and the way in which we conduct our work. So the healthy living listening tour themes, and then we can engage in conversation. So it was really, I think, again, an important finding. There's, when you talk about in our lingo, social determinants of health, nobody uses those words out in the community. Nobody uses them anywhere, really, except for in the public health field. But everybody felt them, right? That cost, transportation, and skills are major barriers to healthy eating. There was no sense that we shouldn't be eating healthy, but rather it's really hard to carry 3 bags of vegetables on a bus. That's just not that easy. And so in the winter in particular, the residents were like, we eat frozen vegetables only because I can't carry all that stuff on the bus. And if you're bringing your children, it's more expensive. And that healthy eating and regular exercise are sometimes undermined by the stress and realities of daily living. And we had a resident who was a great quote. She's like, this is a societal issue. But those who have additional resources in their lives, whether that's a car or whether that's, additional finances available, they have the ability to overcome those humps, coming home late from work, not really wanting to cook, etc. But many of these residents didn't feel like they had that extra reserve, if you will, to overcome some of the challenges that relate to eating healthy, getting regular exercise, doing those kinds of things. So very interesting theme. A lot of residents talked about their interest in a walking group. We had a great conversation. One of the properties that had some yoga, they were like, no, not so much on the yoga. Zumba, maybe, something fun, but no yoga. And another property was like, we loved yoga, it was great. So again, one of the points of this is listening helps us guide with programming that resonates more with folks. And so just an interesting opportunity for us to listen and to hear what residents are most interested in. So we did ask them, what would you do if you got to wave a magic wand and make this all work better? What would you pick? And then these were really the things that came up from the residents that support for applying for and maintaining public health insurance. I live in Colorado. I was born and raised here, and I work daily to try and improve CHIP, Medicaid, and our public health insurance programs, and they are getting better, but they are still incredibly difficult to navigate. Our computer systems don't always work right. You get these letters that don't feel like you can even understand what they're trying to ask you to do out of them. So those are all things that are in progress, but what the residents said is without the resident service coordinators, their ability to maintain benefits and manage their benefits and changes in transitions would really be very difficult. And so that's something that can be done at the level of the housing property that residents really thought were important. Basic primary care kinds of things that may not require access to the full healthcare system, if you will, but on-site delivery of flu shots and immunizations, some on-site nursing and health navigation. Some of the resident service coordinators did share with us after when we did some debriefs that they had invited mobile vans before to come to the properties, and not that many people had used them. And so this on-site piece, and when we heard this differentiation of appreciation for the kinds of providers, I think there's a lot of careful planning, for those communities that may not feel getting care from a nurse practitioner is what they were looking for. Bringing a couple nurse practitioners to that property may not hit the mark. And so it's not as easy as can't we just have the van come by, is what the residents shared with us. Case management, and then, again, some on-site care with mobile vans and visiting nurses, but with a caveat. A couple of the residents said, yeah, I knew it was there, but I wasn't, it wasn't in my day to stop by and get our kids' teeth checked or whatever it is. And then this notion of easier to manage and more rational health care and food assistance benefits, that to find a way to not make it feel like every time you take a step forward, the system puts another barrier or another regulation in way that doesn't allow residents to feel like that the assistance they're getting is aligning with the aspirations they have as they move forward. Improved access to adults, including access to dental, vision, and behavioral health. I think Susan and I talked, we went to one of the family properties, and we anticipated fully that we would hear only about the kids, because that's what we thought would happen. They were like, the kids are fine. Us adults, we're having such difficulties. So it was really interesting and something, again, that was important for us to listen to. But improved access to care, supports to increase access to healthy foods, exercise, opportunities, and education. A couple of the residents said, I took that cooking class last year, and now I make stir fry all the time, and my kids love it, and it was so great. And then a couple of the other residents were like, can we have that class again? Because I'd like that. So this notion of supporting those. And then the residents, again, just ask that we make a commitment to compassion and decency, that's something that they would appreciate, and that, again, doesn't require us moving the mountains of healthcare and housing to realign in ways that are more rational, but rather just a commitment to being more humane. So those were the residents' ideas to improve health. I'll stop there. Yes, ma'am. Sure. So I'll answer the first question first and let Susan talk about the resident service coordinators. We had between 12 and 6 residents at each of the listening tours. So we went out to each of the 6 properties in Mercy, and either at lunch or at the dinner hour. The only slight difference being the refugee populations at the Grace Apartments, because we needed translators. So we all went on one night, but we broke into 4 different groups so that we could have different translation across the 4 different predominant language groups. So that was a much larger group of people, but then they were broken up into smaller. The one thing I will say on that, and when we had a follow-up meeting with some local experts here in Denver, I think it is fair to say that these are highly engaged residents at the property, right? They were, the resident service coordinator was able to say, come, sit for 2 hours with us, we'll feed you pizza. And so I think that has to be part of the truth of this work, is that the surveys were probably a little bit more representative of the entire population, but those who talked with us at the listening tours were probably the more engaged residents in the properties. Yes, ma'am. Yes. It hurts. Mm-hmm.
So what are we doing to help the healthcare people get the information so that they can be, I know they want to support, I know they want to lean in and help be compassionate and provide services for one another.
Right. Yeah. So we've done that. That's a great question, and thank you. We've done it in sort of both a formal and an informal way. So the formal way is that the listening tours were really supposed to be a kickoff to a 3-meeting series. So we had a meeting in March, at one of the local health foundations where we invited folks from housing and healthcare to come and have the exact same presentation we just gave you. So this is what we heard, this is the process. And then from that group, they identified a couple of opportunities, and it sort of split, as you might imagine, between healthy living supports and realigning the healthcare system to better meet the needs of these individuals. So we've been a little bit torn on this next meeting, which was supposed to be designed to bring in national experts who've really figured this out and to guide us here in Colorado and Denver to how we can get this to be better. So that meeting is actually going to be in June. So we've had these sort of episodic meetings that we're trying to help people move along the journey to see how we can explore. One of the advantages we have is that the Medicaid program in Colorado is using what's called an accountable care collaborative opportunity. And so we have extra resources within Medicaid to allow for better linkages and care coordination and that kind of thing, which is really only about navigating the system. It's not about shifting the way the work is being done. So that's the formal path. And the informal path has been at every opportunity since I managed the Coalition for the Medically Underserved that I have the opportunity to engage with these providers. We put this into a nice 10-page document. I bring it with me and hand it to them and say, think this might be useful to read. And maybe after you read it, we can meet and talk about how we could work together to fix some of these issues. So that's the informal way that we're trying to infuse it into a variety of the different healthcare settings. But I think the end of the story is not yet written in terms of how to make a difference on this. And the opportunities of health reform, I think, give us that opportunity, because in the past, when those 28% of residents were likely to remain uninsured, the conversation was shifted in sort of how much uninsured capacity can each of our healthcare systems handle, et cetera. Now that we are expanding Medicaid here in Colorado, I think the conversation will shift to, as we have all of these new residents who are now new insured, what's the delivery system response to engaging with us? We'll see. It's not yet done. What are your thoughts? Yes.
So it's about the individual, not the person.
Mm-hmm.
But like this specific chip, they all think it's a big one. And it's about what healthcare providers are in there.
Yep.
And how those healthcare providers, even though they may be part of a larger system, it is sitting in the policy table. So they'll hear it from most people.
Yep.
But healthcare providers want to be better today.
Yep.
I mean that, they will be, they will give us information and they'll say, what can I do differently, or what can I do? I just think everyone knows what is Medicaid and
Right.
But also just, there are some players that want to do better, and if they have information,
Yep. Mm-hmm. And that's certainly, I appreciate that perspective and agree with you fully. And that's a little bit how we've been approaching the healthy living issue, because that very much felt like it was a local solution driven. And so we're circling back on that, some of those supports at the local level. So it's good advice for us to do that with the care stuff as well. Yes, ma'am. Mm-hmm. Right. That's a great advice as well. Mm-hmm. 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 Yeah. Right. Yeah. Mm-hmm. Yep. Yeah. Mm-hmm. Right. And that is one thing, I appreciate that comment for a variety of reasons. The other thing, though, that it prompts me to just say, the residents felt that compassion on behalf of the providers as well. They were like, they don't look like they're having any fun either. I mean, they were like, we feel bad for them. There's, every time they walk out, there's a whole waiting room of people. They're being forced to see as many people as they can see. It's the economics. It's how they get paid. They don't get paid well for seeing Medicaid. We understand why they limit. I mean, incredibly astute observations on how the system is creating barriers for both providers and patients. And so there was a lot of compassion and some laughing among the providers or the residents. They were like, oof, that doesn't look like much fun either. So I think that it's important that the residents felt that, and I think it's an important piece for us to engage the providers as well. Ma'am, you had something. Any other feedback or guidance? Yes, ma'am.
Our responsibility is that the very nature of PR is to take care of the residents. So what we do is very clear survey and healthcare and sort of in the middle of that fourth reach out to take care of them and that. But so there are a lot of options even for them. For us, there's a lot of it's also we don't take for granted that the funding is providing care that we have to reach free after recognition or power, hidden in a second floor that they can So we sort of see, was there ever any discussion? I know more about Denver from the side of it, I don't know. So I'm assuming that there's a public housing primary care designated. Is there ever any discussion of putting that up front? Because as much as it hurts, we have to hear that to know how to better, I mean, we hear a lot of, we didn't even know you were there. And I'm like, there's not. There's a lot of that. The source of, is there ever any talk of doing that together? Because I think I agree with this sort of while the top line approach that is great, necessary. You have more ownership from the healthcare side if they don't get involved in and there's a lot of reliance that we then have as developers on the housing side.
Right. Well, I think that's what this is designed to begin that conversation. So we're not very far down, as you might imagine. The listening tour, all 6 of these conversations happened in January of this year. So I think it's great feedback from from the discussion, and there's lots of folks from Denver Housing Authority here who might be able to provide additional guidance. But I think that that's the kind of, we were hoping to have this dialogue to get some guidance from you all as well. I think that's certainly what we have to do. And as with everything that's happening right now, Denver's hospital structures are facing the same challenges. Everyone has huge consolidation, drawing of county lines and boundaries that don't make sense to the way anybody lives their lives, but makes somehow economic sense to somebody. So that overlaying structure is happening as we begin this conversation.
Yeah, and I think the only other thing I would say is that, when I wasn't around when Mercy made the decision to kind of structure the survey the way they did, but we didn't have all these grandiose plans to be working side by side with CCMU and trying to influence the healthcare system when we began. It was really, we just need to collect some data. I mean, we have a sense of what's happening with the healthcare of our residents, but we don't have any really systematic way to know what's going on. And so it was really an opportunity to give us at least a snapshot of what was happening. And I think what we've learned since then was how interesting it was and how much more we could possibly do with this data. And also that the data alone didn't tell the full story. Right? We really had to have the deeper conversations and have a much, and I think it's, as much as I'd love for it to be a short-term conversation, I think it's going to have to be a much longer-term conversation between housing and healthcare to figure out some of these complicated things. I don't remember that. There were people who were scared because they were going to get in trouble if they couldn't be seen right away and get a note for missing work if they were sick. And
that was
so,
one of those TANF rules that if you don't, if you miss a work, you know more about this, a work training or something, and you don't bring the note from the doctor, then, and you know, they were like, I've got a sick kid. The last thing I'm worrying about is whether I get the note from the doctor. You know, so that was one of those system structures. But
they're like, yeah, if I have to go to the ER to get the note, I have to do that because I can't, you know, I can't get in trouble. So that's what we heard related to work. I'm not sure we heard anything. Mm-hmm. Mm. Yeah. Mm.
yeah.
Yeah, it is sad, but it's, yeah.
The only other thing we did hear is, you know, one resident shared that she tried to get an appointment because she had a very significant cold, and the answer was, well, the next open appointment is 5 months from now. And she said, well, I'll take it. And then for the next 5 months, she just took notes of all the things she wanted to talk to the provider about when she actually got to that appointment. She's like, my cold was long gone by then, hopefully, which for not 5 months, but that she's like, I knew it was the only chance I would get to address some other healthcare issues I'd been having. So she kept that appointment, which was no longer at all related to her cold, but she had a list that she had created to go engage the provider with.
Yes, ma'am. Mm.
And the problem I run into is customer service because they have really good knowledge of how to and then I do get the reporting to the so I've been like doing that for like 2 days straight and I'm
Yeah.
you know, and that's the problem is that's the thing I'm dealing with.
Yeah.
And it's just like and I'm frustrated because I just like
No, there was a lot of discussion about that. Yeah. And in particular, the refugee families, as you might imagine, many have lived in camps for a long time, and then they find themselves here. And the notion of navigating their Medicaid benefits, as well as the complex healthcare system in Colorado, I mean, it was just, you know, I actually have a colleague of ours who's Pakistani, and he was building some relationships with some of the refugees, and one of them asked him to come over. And he came over, and the entire apartment had been cleared of its furniture, and there were 40 people there to have Dr. Malou explain stuff. And people had mail, you know, because if you live here, you know that pharmaceutical mail is junk mail, right? Out the window. Or, you know, those kinds of things. Not clear to you if it's not in a language that you're familiar with reading or speaking. And so, you know, Jamal said that there were residents there with stacks of paper to help him. And he was sort of recycle, keep, you know, just a very interesting. And he thought he was just going to help a resident look at something. I don't know what he thought he was doing. But very, you know, especially for the populations that are new to the state of Colorado, incredibly difficult to navigate a system that's incredibly complicated.
And I think the other thing that is that, you know, a lot of the refugees, and, you know, I'm sure they're not the only group, but you know, they're just not aware of sometimes of what health services are out there. In particular, I think about this brand new school-based health clinic at Placebridge Academy for kids. And Placebridge Academy is almost exclusively immigrant and refugee children, and parents had no idea that that was there. None. And that's a school that does a part of communicating with refugee parents, but they're like
Gretchen was saying, there's just such a huge hurdle there culturally and linguistically to be overcome. We're not doing enough to bridge that. Yeah. Mm-hmm. 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 Absolutely. Yeah. Mm-hmm.
Yeah, I think we heard some of that, and one of the residents shared that she had been to the ER and it was just a not very fulfilling experience. You know, she's like, I waited 4 hours, I got the one thing I needed, then I got a big bill, and I didn't get any. So, I mean, she said, you'll as much as have to drag me there the next time. And so,
it's interesting for those of us trying to make sure the system is ready for health reform. One of my colleagues who works in substance abuse said, you know, people throw this word pent-up demand around. He's like, I think we need to reframe it as pent-up need. There may be pent-up need out there. Demand may not be the first thing. And I think after you reflecting on some of the experiences of these residents, there's pent-up need perhaps, but not necessarily demand, because they have felt so excluded or navigating the healthcare system as it exists today is just such a hassle that there may be pent-up need, but not necessarily pent-up demand. And so I have appreciated my colleague Frank reframing that concept for us. He was, again, talking about substance abuse, but I think it's similar for those who have been traditionally medically underserved and may not have a lot of trust or appreciation because they're not treated with trust and appreciation by the healthcare system.
Mm-hmm. 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 Right. Right.
Yeah.
Yep.
And I think we're seeing that disruption. I'm not going to get the statistic wrong, but, you know, Walmart has an intention of putting X thousands of sort of retail clinics in all of their sites. In Colorado, we have some of those retail clinics at the local Walgreens and others are beginning to do chronic disease management beyond just sports physicals and sort of one and done. They're doing chronic disease management. And so I think we're seeing disruption in healthcare in general with convenience and closer to the folks, letting go a little bit of that primary care medical home. Now, again, if the data all worked right and there were smooth transitions for people who need higher levels of care and support, I think that'd be great. But I think we're going to see that disruption, and it's going to penetrate. You know, the other thing that we haven't mentioned is in Colorado, we have an emergency department war going on. Most of our major hospital systems are building standalone emergency departments that are really designed to funnel people into their hospital system. And, you know, I had a friend of mine say, you know, those affect people on Medicaid. You know, the big billboard on Colfax that says ER wait time at XYZ hospital, 3 minutes. that affects all kinds of people. That affects fully insured people. It affects people with Medicaid, and it affects those who are uninsured. So the larger cultural context of driving emergency room utilization as profit is something that we can't deny is happening in the healthcare system, and it impacts everybody. It impacts all of us, including those residents of Mercy Housing and others.
Mm-hmm.
Yeah.
Yeah, but I think
Yeah. Yep. Yeah. And yep. Yeah. I think we're seeing it a little bit in some of the urban, but I think it's an important point. Absolutely. Right. And I think to your point, we have found, and we were very surprised at the frankness with which many of the residents spoke about mental health care coordination with that many of the resident service coordinators are social work type trained individuals, and so care coordinating around mental health services, up front and center in our conversations, people saying, I really liked that therapist, I didn't like that one, I like the group sessions, I don't. So a very open conversation already flowing in these properties around that kind of care coordination around mental health services, and so I think that's an opportunity to continue it around others.
But I think it won't surprise you that it's even though resident service coordinators play a critical role, it's not the only solution, because there's still going to be a lot of people in properties who don't want to interact with resident service coordinators, who want more privacy, they want to be more removed from the resident or from people knowing what their health issues are. And so it really does require having a lot of different strategies, I think, to meet some of these complex needs.
And sometimes the resident service coordinators can't penetrate either, right? I mean, you're stuck on the phone trying to make, navigating the healthcare system can be difficult for those resident services coordinators.
Yeah.
But I was just saying that's the thing is, like, a lot of times they don't understand being built in that sense. It doesn't say anything about, calling that kid or if you have medication. It just says you owe everything to the out.
Yeah.
He's the same guy that I encouraged him to go to the dentist, and his copay was $15. He had Tuesday, and he was like, taking him for 2 weeks. I had to encourage him to go, and I'm like, no, that's what he pays, $15.
Yeah. Well, and I think, I think that was the issue related to cost. That just the confusion of medical bills, all of that. And so to some extent, it is at times it's the upfront barrier, even before they've incurred a cost. The fear of cost or previous experience incurring costs is a barrier. Well, thank you. I think are we up on time? Yes. So thank you all very much for the opportunity for us to share. Susan,
thank you so much, and we hope you enjoy the rest of the conference. Great.